Good afternoon, everyone. Thank you, Jerry, for inviting me to participate in this instruction course. So I'm going to take you through the genetics of corneal dystrophies. With that background, you already got, all of you are probably already into genetics, and it's nice to know what's going on and where we stand with respect to therapy. So, why go for genetics? It's quite expensive, it may seem esoteric, and it could maybe be interesting to know in a particular patient what is the gene, but then what do we do after that? Also, there's a cost involved, which again, and you know, patients are very, very hopeful. Like you've done the test and they come and they want to know the report, and then they expect you're going to do something magnificent with that. So that is another thing which you have to deal with. Now, in a country like ours, we have our own special gene pool, you may say, or ethnic variation. There are a lot of uniqueness in the population in India. And in the field of ocular research, there's lots that can be done for molecular genetics as well as epidemiological studies. And then interventional strategies as well. We could take a holistic approach and also multidisciplinary policies. So there are certain global initiatives because, for example, research and funding opportunities where you put together the clinical, basic and operational departments. There is an Indo-US Vision Research program going on, and several institutes in India have taken the opportunity to join up with collaborators in the United States. There are certain strengths that we have and there are certain strengths that they have, and putting this together can be a win-win. So there's a DBT-NEI, then there's an Asian Eye Genetics Consortium and the Global Eye Genetics Consortium. Nationally, we have, of course, for within ourselves also, we don't, if we don't have to collaborate internationally, we have sources of funding with the DBT, DST, ICMR and CSIR. Now about ethics. So ethics again, there are certain protocols to be followed. The information is supposed to be confidential, and largely the country has taken a stand that we would rather not have samples going from India abroad. We would rather have capacity building in our country itself to have the wherewithal to test and to interpret. There could be sometimes a conflict of interest and finances involved. So all of these need to be kept into account if you're going to have any collaborative plan. And then we have molecular genetics and functional analysis. So this is where ophthalmologists may not be fully equipped to manage on their own, and you need to find an interested geneticist. What I found is many of the geneticists, they have not been that much motivated to work in ophthalmology because they have a whole host of diseases to work on. So there are few very limited geneticists in our country who are attuned or aligned towards ophthalmic research, and that is something can be a challenge, but one can always look around, and in your own institutes you may find somebody who is willing to work in this area. Now, a little bit about our experience, how we started off in the cornea services, the Dr. Rajendra Prasad Center. We do recognize that there are unique populations in India, and certain developments have taken place over the last 10 to 15 years. People who are not corneal specialists may have learned in their post-graduation that you have epithelial dystrophies, stromal dystrophies and endothelial dystrophies, and a whole lot of names were there. And it is only with the explosion of information which came with genetics that they were able to now categorize these disorders better. So ultimately they took the genetic report as the holy grail, and often there was an overlap. So what you would think clinically is one type of dystrophy, when you saw with the gene, I'll give you examples later on, there could be a overlap. So you could have the same gene with two different phenotypes, and sometimes a phenotype with different genes involved. So the International Cornea Classification of International Cornea Society Classification of Corneal Dystrophies was proposed in 2008, and then it was updated in 2014 and 15. So as I explained, traditionally it was anatomically defined depending on which disease was the predominant disease layer affected, and then it was revised because it learned that most dystrophies are not confined to one layer, and as scientists we like to be as accurate as possible, try to be as close to what is actually going on as possible. And then there are categories depending upon the information available for the identification of genes and chromosomes. So for those people who are wondering in the beginning that what's the use of knowing the genes, this is one very good example of how having the genetic information has considerably helped the cornea fraternity in being more organized in their diagnostic process. So as I said, here are a few examples. We have the Rees-Buckler corneal dystrophy. It affects more than the subepithelial layer. Then the macular corneal dystrophy technically now is known to affect both the stroma and the endothelium. And the other changes that the IC3D did is it excluded the Bowman's layer and Descemet's membrane. There were Bowman layer dystrophy and Descemet membrane dystrophy earlier. That has now been removed. It removed the table of genes separately and incorporated it within the classification. The very big change has been in the classification of CHED. We used to have CHED type 1 and type 2, autosomal recessive and autosomal dominant. But this CHED type 1, which was considered autosomal dominant, has now been considered that it's not a distinct entity at all. It is a variant of PPCD, posterior polymorphous corneal dystrophy. And then they included 3 variants of epithelial recurrent erosion dystrophy and removed the Grayson-Willebrand corneal dystrophy. Now, why did they remove these? Because they found that these were terms, and of course, at the time that these were described, great credit to the ophthalmologists who carefully watched their patients and took the trouble to characterize and define. But as science grows, we have learned more, and so therefore they found that it was overlapping and did not have to have a single eponymous entity. So, in terms of the categories, here I would like to say it's something like the levels of evidence. So, we have 4 categories. If the genetic locus is known, the gene is known, the features are well defined, then it comes as the highest category 1. Here we have the example of CHED2, which now is just called CHED, early Fuchs and PPCD 2 and 3. On the other hand, if the genetic locus is known, the gene specifically is not known, the features are well defined, then it comes in the category 2. So CHED1 was coming in this category, but now it is being clubbed in terms of terminology with PPCD type 1. And so as you can see, PPCD is now divided. What earlier was a basket diagnosis of PPCD, now it is there, but it is divided into categories, and the late Fuchs as well. Then category 3 is a sporadic Fuchs, where genetic locus is not known, the gene is not known, the features are well defined. Now question is, why is it here? Because you don't know the genetic locus, you don't know the gene, only the features are well defined. It's still here because it has been found in families, and the evidence considered felt that it still has a place to be here. And then category 4 again, where the genetic locus is not known, gene is not known, the features are not well defined, and the example here is a pre-Descemet's membrane dystrophy. So here, this is freely available. You can check online, and this is the way things are as of today. Now, what is the journey from AIM? So we had felt that a lot of there was a need to put like-thinking people together, and we were considering that we would apply for an Indo-US grant, or at least for our own country define what are the areas that are worth working on. So we had ophthalmologists and geneticists from all over the country as a national think tank and a brainstorming session to do a workshop on formulation of a national action plan. And this is also combined with low vision and rehabilitation services, because a lot of the retinal disorders, there is no treatment available, and it was important that we have to provide some kind of support to such patients, and it's very important to upscale and upgrade the facilities available. So in the introductory section of the genetics group, there was a meeting, there was discussion, and it was agreed that that 3 areas were felt as important to work on. One was CHED, because it was felt that it is unique to India. The other one was retinitis pigmentosa. So these are the 2 areas which was felt our priority. And there was a concept that maybe we should try, we should start a genetic society, like the Society for Study of the Genetics of Ocular Diseases in India. However, simultaneously, the Asian Eye Genetics Consortium came up, and then the Global Eye Genetics Consortium. So we have not formulated our own separate society, but there was a lot of great brainstorming, and we decided that we will collaborate together. And as far as the work done nationally, there's a lot of work going on in cornea, glaucoma, optic nerve, retina, and retinoblastoma. Now, a little bit of our own experience, molecular pathogenesis underlying the corneal dystrophies. Now, the other question is, with so much already known all over the world, is there any benefit of doing studies in certain areas? So here is a few examples. So the features of corneal dystrophies, we know that they are inherited disorders, there's equal frequency in males and females, there's a gradual progression, and they're usually not associated with any prior systemic disease or inflammation. We wanted to see that what is the distribution of the corneal dystrophies in North Indian population, because there weren't any studies or any reports from the north, and this is the range of the corneal dystrophies, and we were able to find some interesting findings. We combined it with the histopathology as well as the phenotype. And several unique mutations were found, and some of them were common, but they were first reported mutations, some variations, and certain novel mutations as well. And this work has been done along with the genetics department, Dr. Arundhati Sharma from the Department of Anatomy, the genetics lab. So we've also found a novel mutation for granular corneal dystrophy, then the Reese-Buckler corneal dystrophy. Now, if you look back, typically this would have been diagnosed as a granular corneal dystrophy, but the genetic information has helped us define what the disease is exactly. And this is an example of an Avellino corneal dystrophy. Now, I found with the genetic information, I was able to look at the clinical pattern again, and I found that when you have these linear deposits, I mean the opacities have a kind of radial pattern, that is more likely to be Avellino corneal dystrophy. And the purpose of the study was to see if we can do a genotypic and phenotypic variation and mapping to see if one can predict the gene based on the clinical parameters, but unfortunately it is not that simple, and you do require the genetic report to help you. And this is an example of a lattice corneal dystrophy. But if you see this kind of pattern, you would, the other thing that we noticed is there's a lot of change in the phenotype because of the nature of the population as well as the country. So you may have dryness, you may have associated trachoma, you may have associated infections that the patient may have had. So that may also change the phenotype. So it's very important to have a proper documentation of the history and the previous records of the patient. These are examples of another novel mutation that we found of MAP-dot fingerprint dystrophy, and these are the pictures of the sibling, and the patient had MAP-dot fingerprint dystrophy, and the sibling clinically had granular corneal dystrophy, and this was the mutation. And this is an example of macular corneal dystrophy. And then macular corneal dystrophy, as you know, is an autosomal recessive inheritance. And largely we found that the mutations were reported, though there were a few novel mutations. And you can see there are 5 novel mutations which have been discovered. And this is the molecular genetic analysis. This is an example of the novel mutation. So in conclusion, no coding region changes identified in 32 patients, both new coding encoding as well as upstream regions. They were screened for TGF-beta-I, and there was no mutation found in them. And we noticed there is genetic heterogeneity. So the coding regions, splice sites, upstream regional mutations were not seen in all our cases. Now coming to the endothelial dystrophy. So we looked at Fuchs dystrophy as well as CHED. And the number of specimens we had for CHED were 59 males and 41 females, and 39% did not have a familial history. So this is an example of the Fuchs dystrophy cases, and this is an example of CHED. And another interesting thing is that some of our patients, they have CHED, but they have reasonable vision. So they have navigational vision, and they avoid, or they were never offered, corneal transplants. So we had the opportunity of having patients as old as 40 or 50 years old. And they also had the secondary changes, such as you can see here, the lipoid dystrophy and so on. So this is example of Fuchs. And then Descemet's thickening seen on ASOCT, subepithelial cystic spaces. Guttate changes can also be picked up very nicely, and the specular changes and histopathological features of JED as well as Fuchs. And the SLC411 gene was detected and a molecular genetic analysis was done. We did find, however, that not all of our patients we could identify the mutation, so we are further processing the samples to see if we have any a whole genome sequencing is planned, though we have found a novel mutation in 2 patients. So no mutation was identified in 21 patients, and the existence of genetic heterogeneity with overlapping cases was confirmed. And for Fuchs dystrophy, the COL8AA2 gene was screened for. Total of 30 patients were recruited, and all the codings were amplified. So I'd like to acknowledge the Department of Biotechnology, for which I was the principal investigator for the project, along with Arundhati Sharma from the Department of Molecular Genetics, and the Cornea Services, Ocular Pathology, and the Department of Anatomy. With that, I'll end here. Thank you so much.